Thank you. Thank you all the participants for joining us on time. So sorry for the video off. I am a little under the weather, so my voice is also a little weird. Thank you, Frank, for holding on to this program. And every week we are having discussions over discussions and learnings. And so happy that we decided to do this series. So before handing over to you, Frank, with your permission, I'm just taking a few minutes in the beginning. We have Dr. Noble. He's a professor in nephrology in a public tertiary care hospital in Trivandrum. I think it's one of the place where you see maximum number of patients in nephrology. So I'm glad that we know that most of these participants in this group are from the palliative care community, learning to know how to cater to patients with patients on end-stage renal disease. And now here we have someone who is on the nephrology side, who understands the need of palliative care in nephrology. I think that speaks, that holds a high value. That's very powerful than many of us talking together. Dr. Noble, can you speak a few words for us regarding what is your identified needs as we had discussion? What is your purview about palliative care?
Thank you, Sridevi and Parliamentia for inviting me for this session. I am actually not introduced to palliative care in nephrology, even though I have the need. I felt the need when Dr. Sridevi and the team came to me and told about what is the prospects of palliative care in nephrology. The main issue we face is from the ongoing nephrology side, that is patient with terminally ill cancers with severe renal failure, which is not, they are not undergoing any chemo, not undergoing any radiation, but they just, because of the renal failure, they are referred to us to take care of the illness. And relatives also think that entire problem is due to its renal failure, and they leave that cancer side aside and tell us, please do something for renal failure. So we are actually in a fix, and they won't have a good access, and they don't tolerate hemodialysis well. And with the peritoneal meds and all, we can't put a PD catheter in. So a lot of these issues. Another group of patients we see is 85 to 95-year-old debilitated individuals with severe renal failure, coming with nausea, vomiting and all. And also they're very frail, and we couldn't start them on any form of renal replacement therapy. And relatives also cannot understand whether they want somehow we should reduce this creatinine, it reduces urea, and the entire problem is due to its renal failure. This is another group. Another group we face is, since Kerala is a diabetes capital, we have a very bad catastrophic diabetes with amputees, with very bad vessels, calcified vessels. But age will be around 65 to 70, severe heart disease. And whenever you put them on dialysis, they'll fall in for hypertension and sometimes die also. So these patients also, we are in a very difficult situation, whether to offer them renal replacement therapy or go in for palliation. And the word palliation, in at least in our society, feel that we are helping somebody to die without doing anything. So that actually the relatives are not willing to accept that notion of, in spite of having high blood urea, high creatinine, you people are not doing anything to bring down that and help the patient out of the situation. So these are the situations we commonly face. And Frank, you can better guide us through how a nephropalliative care will be feasible, especially in our context and our society. Thank you.
Thank you so much for your time, Dr. Noble. It's wonderful to hear from the other side of the spectrum, where we are discussing. Last few sessions we were discussing about managing symptoms, and we have Dr. Frank. I'm just introducing you both. Dr. Frank works in Australia, has done immense amount of work in nephropalliative care. Whichever readings that you take as evidence, Frank has his mark on it. and he's the right person for taking this forward. Thank you so much, Dr. Noble, and I hope we'll be working together more for nephropalliative care. Thank you so much. Doctor, I hope you have time for being with us during the session. Maybe.
Yeah, sure, I'll be here. Yeah.
Thank you, sir. Over to you, Frank, for today's session.
Thanks, Dr. Sri. And thank you, Dr. Noble, for those comments. And hopefully we'll have a chance to perhaps talk to those a little bit later. Now, first of all, as I begin with each lecture, just to make sure that everyone can see the slide.
Yes, Dr. Frank.
Yes.
Slideshow would be good. Yes.
Okay. So you can see the slide there.
Yes, first slide. Yes.
And I'll just make sure it moves. Does it move to the next?
It is moving.
It moves. Very good. Okay. So just as a preliminary, what Professor Noble has just said is remarkable challenges, aren't they, for nephrology in terms of those very seriously ill patients and what possibly you can do in response to the clinical need, but also what the patient's family are requesting or expecting. And hopefully we'll have a chance to talk about that a little bit later. So Professor Noble and the entire audience, as you know, this has been a 4-part series. The first lecture was on an introduction to what kidney supportive care is and looking at that. And then the next 3 lectures have been on particular symptoms. So let's then start. So we're going to go through in this lecture upper GIT symptoms part 1. Last time we spoke about taste changes. We'll also speak about depression, cramps, and then end-of-life care in CKD. So this time we're going to talk about other upper GIT symptoms other than taste. I'm going to concentrate on anorexia, nausea and vomiting, and early satiety. Anorexia. Anorexia is multifactorial, as we all know in palliative care, and indeed in nephrology, and every discipline understands how multifactorial this particular symptom can be. So lots of things can contribute to this, including things like nausea, dry mouth, altered taste, and we spoke about that at length at the previous lecture, delayed gastric emptying, depression, uremia, inadequate dialysis, abdominal discomfort and swelling from CAPD. I'm going to turn to a couple of these in more detail, but just look at that delayed gastric emptying. Now, uremia can cause delayed gastric emptying or gastroparesis, but diabetes can cause autonomic neuropathy and gastroparesis as well. So there might be several reasons the person has got gastroparesis. But these is a long list of different other associated contributing symptoms into the anorexia, isn't it? So when a person says to me, I'm not interested in food or drink, I'm starting to work out how can I best approach taking a history from this person? Because I'm just going to try and work out what the source of this is. Is it because the person has lost their sense of taste? Is it because of nausea, gastroparesis, potentially depression, inadequate dialysis, etc.? So this is probably very helpful for us in terms of coming back to the source. And this has perhaps been one of the themes of this series of lectures. Now, I'm not able to move the slide next. Just see if I can.
What if you can go back and then come again?
Yes, I'll just see.
Or can you click on the screen first and try changing the next slide?
Yes. Okay. Perfect. So patients on dialysis require 2 times the amount of protein of a non-dialysis patient. And so the issue of chronic protein energy malnutrition is common. This is a substantial topic and yet another challenge for renal patients in terms of how they're going. So I guess in terms of what we try and do with anorexia is attempt to reverse the reversible cause, deal with the nausea, deal with the gastroparesis, etc. And also, if you do have a renal dietitian, that person's going to be extremely helpful for you. Nausea. So again, I think it's important to look at the causes here, or the cause or the causes. Uremia can alone set off nausea, triggering the so-called chemoreceptor trigger zone. And those in palliative care know about the mechanism of nausea, the CTZ being extremely important. We've talked about delayed gastric emptying or gastroparesis, concurrent medications. Good example would be digoxin toxicity, of course, or opioids potentially. And constipation, never forget constipation as a cause of nausea. So lots of different reasons there. Now that's a fairly simplistic slide, I grant you, because there may be other causes of nausea here, but these perhaps are the common ones that we do see in the clinic. So in terms of going to the reversible causes, absolutely. Then treating the symptom. So we use medicines such as metoclopramide, haloperidol, cyclizine, ondansetron. Ondansetron is very favoured here in Australia, but the trouble is it's very constipating and may, in fact, ironically, set off terrible constipation and further nausea. But it's often those first medicines there that we do use. But we just need to be a bit careful here, and that's being aware of side effects. I'll just give you an example. This particular man had kidney failure. He was on hemodialysis. Home hemodialysis. His main symptom was nausea. We commenced him on metoclopramide. 2 weeks later, he said, "Doctor, my nausea is very well controlled, but my legs keep moving at night." We'd actually precipitated restless leg syndrome. Why? Well, if you remember the lecture on restless leg syndrome, it was all to do with this. It was all to do with a disruption to the manufacture of dopamine, particularly at night. And you remember the issue being the deficit in iron transport into these cells in the basal ganglia, deficit of dopamine at night. So if you gave metoclopramide or haloperidol to a person, they're both dopamine antagonists. So unfortunately what we did, and I stumbled here, thinking I was really solely looking at nausea, but using those medicines precipitated restless legs. So now, if a person has nausea, I will ask them, before we get to the management, I will say to them, do you also have restless legs? Now, they look a bit puzzled at you as to why you would ask that question. And I explain, because I just need to be careful with the use of my medicines, because if they do have restless legs, I'm not going to use metoclopramide or haloperidol. In fact, what I will use is motilium, otherwise known as domperidone, 10 milligrams TDS, a very good anti-nauseant and a prokinetic, and that's very important, stimulating the stomach to empty, but it barely passes the blood-brain barrier, so it's a very good use. So with nausea now, I don't rush to Mexilon haloperidol. I'll always say, do you have restless legs? If you do, I think we're going to start you on motilium or domperidone. Early satiety. Well, the two main reasons for this, as I said earlier, is uremia can cause slowing of the emptying of the stomach. And in diabetic patients, they may develop diabetic autonomic neuropathy and gastroparesis. So this can be a significant story. And one of the classic stories for diabetic renal patients is waking feeling quite nauseated. Why? Well, through the night, gastric secretions have come into the stomach and they've just been lying still. Suddenly they're standing and they're feeling very full with the secretions, and they may feel quite nauseated. They may even vomit. So in those cases, I'll give an antiemetic as soon as they wake up, so to help them. So as you know, early satiety is a feeling of feeling very full very quickly. So using medications, if they don't have restless legs, I potentially might use metoclopramide, but warn them that they may get restless legs and tell us immediately if that have, but otherwise using domperidone as an antiemetic and prokinetic. So these medicines are quite useful, and it's certainly a story for the diabetics, that early satiety story, yes. Depression. Depression is a large topic, and I'm not a psychiatrist, so I've relied very much in my work on talking to psychiatrists. And also occasionally I'll have a liaison psychiatrist who's very interested in chronic kidney disease, such as Kirsty Morris. So these next slides are prepared with acknowledgement from her. So 20% of patients of CKD have depression, 1 to 4, 21, dialysis 22. So this is quite a story, isn't it? And it can be underneath the surface and undiagnosed. And that's perhaps one of the themes here. The diagnosis of depression in CKD can be challenging. Why? Well, the international definitions, the DSM-4, 5, and as they go on, criteria for depression include symptoms such as fatigue, anorexia, insomnia. And these are the very symptoms that many of our kidney patients have. So it's difficult to untangle that, isn't it? Because you may say, well, this person has all these symptoms, but they may or may not be depressed. So how do we try and get to a diagnosis here? As I said, this is challenging given that several of the DSM criteria are also experienced by patients with CKD. So it's recommended that the diagnosis of depression in a patient with CKD should rely more heavily on psychological features such as loss of enjoyment of life, guilt, loss of self-esteem, hopelessness, and suicidal ideation. So they're the things that I ask for. Because if I ask for fatigue, anorexia, yes, of course, I've got that. But now I'm going to ask, do you have these feelings of hopelessness, guilt, perhaps loss of self-esteem, suicidal ideation? That will be perhaps a better way of diagnosing. There are certain key times when people can get depressed: the first year of treatment, failing transplant, or non-listing for transplant. These are important to do. These are important associations in terms of increased mortality from all causes, reduced compliance, withdrawal from treatment, more symptoms, reduced quality of life, and more disability. So if the person has depression, it may be that they're just not wanting to come in to see you, not wanting to comply, feeling hopeless. This is all too much. And also suicidal ideation, suicide attempts, probably more frequent in dialysis patients, etc., and various risk factors there. Unfortunately, despite these associations between CKD and depression and poor outcomes, and the increasingly available evidence, clinicians remain cautious when managing depression in those with CKD, and rates of detection and treatment remain very low. So I think as a nephrologist, and certainly palliative care working in nephrology, I think it's good to perhaps start to think about this and study this a bit more. Now, we cannot convert ourselves into psychiatrists, that's true. I would also reach out to psychiatry colleagues and say, look, I'm working in a very specific area here. Could you guide me in terms of what you would look for and how you would manage patients with depression in CKD? This will help you a lot. Management. The difficulty is that there are very few studies. So I guess we're really limited to management of depression in the general population, and then using some of those medicines in the CKD population. There are only 2 placebo-controlled RCTs and an antidepressant medication in CKD. So this is perhaps a very good review: pharmacological and psychological interventions for depression treatment and patients with kidney disease. Oh, and by the way, to everyone, and I'm sorry I've been so slow, this evening I've emailed this evening, my time, Australian time, I've emailed Dr. Sri with all the lectures, so you'll be able to go back over these, because I'm conscious that some of the lectures I've needed to move through at a certain pace. So this might be a good paper to have a look at. And they talked about, or Dr. Morris actually, in a detailed conversation with me, said, look, it's reasonable to initiate a cautious trial of sertraline. CBT, cognitive behaviour therapy, is at low risk, possibly effective intervention. So yes, it can be depression, it can be undiagnosed, and it can sit there below the surface. And the difficulty, before I just go straight to cramps, is the difficulty is that we see patients who are fatigued and anorexia, and we think, oh yes, well that's normal for them or normal for that group, and we may not ask them those further questions about their mood, and we may not pick it up, or they may feel they're depressed just simply because they've got kidney disease. So cramps. Prevalence, 33 to 78% in hemodialysis, associated with premature cessation of dialysis sessions, resulting in inadequate dialysis. So I think someone has raised their hand. Now, what I might do is to perhaps answer that question at the end of the lecture, if that's possible. Is that okay? Thank you. So prevalence. So this is quite a story, isn't it? Where people on dialysis or not on dialysis start to get cramps. Now, it's a terrible story on dialysis because the person's just wanting to get up off the chair. It's just too much for them. The causes, fluid electrolyte shifts during dialysis, and muscle fatigue can inhibit the mechanism that blocks muscle contraction. So management, well, we tend to use magnesium as a management of cramps. There is a preparation called Cramp Ease. It's a good name. I'm not sure what in India would be available in terms of magnesium products, but yes, certainly magnesium we find very helpful. Quinine, now there's issues in many countries about quinine availability. There's concerns about thrombocytopenia, et cetera, but if you do have quinine available, or even using tonic water, people do use that as well. L-carnitine is another product that is used. I haven't used it, but people do speak about that. And then there's this other thing which I've never used in terms of pickle juice or vinegar, yellow mustard, ginger, that has a physiological rationale, if you like. You can see that there. Care of the dying patient with kidney failure. So I'm going to move through this, and perhaps then, even if we have, hopefully we have a bit of time to talk about some of the issues that Professor Noble spoke about there as well. So kidney failure patients may die having been on dialysis or never having been on dialysis. And I'm very conscious around the world that being on dialysis may not be possible, not through choice, but through circumstance, simply the cost of dialysis, the financial imperative, the financial burden of dialysis. So many patients are on so-called conservative kidney management because of choice restriction, if you like. So some people are on dialysis, some people are not. But patients with kidney failure may die in many different ways. Look, it could be a sudden death, and usually that's cardiac. Now, that may occur while you're on dialysis in front of everyone. And that's quite a big challenge in terms of resuscitation attempts, the effect on other patients and relatives, the effect on staff. So I'm very conscious of how that can have a profound ripple effect, if you like, on everyone, a sudden death. Or they may die suddenly at home, of course. The shock of and response to a sudden death for the family, health professionals and other dialysis patients and their families who knew that patient, who were so used to seeing that person opposite them on a dialysis chair, and that person's no longer there. So that's quite a story, really. It may be that the person has died after withdrawal from dialysis. So in what circumstances might dialysis withdrawal occur? Well, if that decision is made, there are classic questions. Well, before we get to that, what circumstances? So the circumstances of withdrawal from dialysis would vary enormously. It may be patient-initiated. They may say, I'm exhausted with this. I can't keep going. It may be a situation where the person is now becoming more comorbid, more and more illnesses coming to them. A good example is dementia. They may have started dialysis many years ago when they were cognitively fine, and now they're dementing, and it's becoming clear that this is becoming too much for that patient. What they call failure to thrive, where the person is becoming weaker, tireder, struggling, more symptomatic. It may be that the withdrawal of dialysis is caused by simply financial reasons, that the family cannot continue with financing the dialysis. So that's a story too as well. If that decision is made, the classic questions are the following. Okay, my dialysis is being withdrawn, but how long do you think I will live? So that's an interesting question, isn't it? And I guess over time, we've found there are two cohorts. If the person is anuric, completely anuric, the mean survivorship is 7 to 10 days. But if this patient is still passing urine, it may be weeks or even months, to everyone's surprise. So I think it's really important just to be careful when we're sitting with patients who are withdrawing, when that question is asked, to be aware that there are the two cohorts. Because sometimes what happens is that everyone is told, irrespective of whether they're passing urine or not, that they've got about 7 to 10 days to live. But it may be no, that this person is still passing urine and has got potentially weeks to live. And we've had situations like that where patients are everyone's very puzzled why this person remains alive 5 or 6 weeks later. Well, this is the reason. They've still got some residual renal function. Next question they'll ask, well, what will I experience in this time? What will happen to me in this time? Some patients and families think that if you stop dialysis today, tomorrow the person will be in a coma, the next day they'll be dead. Well, it doesn't happen that quickly. What happens over time, essentially, is a buildup of those uremic toxins that are being dialysed out. And when you start to get uremic toxins build up, bit by bit, you're starting to get more what they call uremic encephalopathy. And I'll talk to you about that in a little while. Essentially, fatigue all the way through to a coma. But in that can be uremic jerks, confusion, and sometimes even seizures. But what we tend to do is I say to the patient, I may not go into all that detail, but I'll just say, look, over days, it's not going to happen immediately. You will become more tired. You may lose all your interest in food. You may become a bit more nauseated. You may become itchy. In other words, you may have restless legs. In other words, and you may start to have uremic jerks. So in other words, all of the symptoms we spoke about through the previous 3 lectures, that's just to be aware of that may occur. But as I say that, I'm always saying, you may get this, you may get that. I'm always going to marry and what we're going to do about it. We'll do something for that. We'll do something for that. So that the family is informed by the sense of, oh my God, all these things are going to happen. So I think it's very reassuring. You maybe become tired. The tiredness will be asleep. You'll go into a deep sleep. You maybe become nauseated, but we'll do something for that. You may become itch, we'll do so, etc. And that will be very helpful. And what can be done to keep me comfortable? I guess that's implicit, isn't it? Certainly for palliative care, where patients are saying, okay, you know, you're an expertise in this area. How are you going to keep me comfortable? And that also could be a question for nephrologists. Well, how can we keep these patients comfortable? Details on the specific management of the deteriorating dying patient will be presented later in this presentation. Where should I be cared for? That's an interesting question, isn't it? So it may be coming home. It may be the person's already at home. They're not in hospital. Or it may be in a hospital, or it may be in a hospice setting, in a community palliative care setting, lots of different things. Okay, so that's the withdrawal from dialysis, and I'll come back to all those symptoms of the dying process a little bit later. But the other context may be the person who's on a conservative non-dialysis pathway. They've never been on dialysis. So their kidney function is going to slowly deteriorate, and bit by bit, these symptoms will come. Do you remember the trajectory from that slide? So this was trajectory of patients on a non-dialysis pathway. This is a study from England, mean aged 80, of people on their Konoski between 60 and 70. And then about 2 months before death, they took to their chair, they took to their bed, they started to become much less functionally able. So I think that that's perhaps a clue that that's the time things are changing. And you remember 2 months before death, there's a symptom increase, and 2 months before death, there's the increase in palliative care needs. So that perhaps indicates if people were to say, okay, someone's on a non-dialysis pathway, how do we know that death is approaching? So that's what we look for, a deterioration in functional status, an increase in symptoms, particularly fatigue. That's a very, and of course you've got the EGFR to look at, of course, and the creatinine as well, that can help as well. So there's limited direct studies in this area, but considerable expertise developed over many decades in the care of the dying patient generally. This knowledge can be combined with known specific symptomatology and lead. So what I'm speaking about now is how to care for a dying patient, whether the patient is withdrawn from dialysis or on a conservative pathway. So we don't have many studies in this area, but we do have a lot of experience in palliative care and how to care for a dying, and then also symptomatology for the CKD patients. The care of the dying patient with kidney failure requires a careful combination of the skills of nephrology, palliative care, and family medicine, and each can learn from each other. So Professor Nephpal has joined us today, and we can certainly learn a lot in terms of renal medicine from him and his colleagues. And hopefully he and his colleagues can learn a lot about palliative medicine from us. And I think that's the answer, the so-called kidney supportive care, the alliance between nephrology and palliative care is the future really here, that no one discipline has all the answers and each can rely and work towards the common goal with each other. I've put family medicine in there because, yes, it may be that the person is now in a community setting and not seeing nephrology or palliative care. So it does require some skills there, of course. So this is an interesting story. I'll just tell you the story. I gave a lecture a couple of years ago in Melbourne to a group of nephrologists. At the end of the lecture, one of the nephrologists put up his hand and said, I would like to tell a story. And the story was the following. There was an 87-year-old man who'd been on hemodialysis for many years. He was exhausted. He was ready to stop dialysis. So the nephrologist described what might happen. This man was anuric, so the prediction was 7 to 10 days. The man said, look, I'd like to stay in this inside the hospital because I don't want to be a burden to my family. And the nephrologist said, yes, that's fine. As the nephrologist finished speaking to him, he said, and he was telling this story, he said, I thought I had nothing more to offer this patient. That was really it now. So I left the room. This patient died about 10 days later. The nephrologist said, I did 3 ward rounds in those 10 days, and I walked past that room. I didn't go into the room because I thought I had nothing more to offer. When the patient died, the family came to him and said, why didn't you come into the room? Why didn't you come and speak to us? And then the nephrologist said to all this great audience there, he said, suddenly I realised it was more than the technical, it was the personal. They wanted me personally there. Now, I would say at the end of this lecture that there's many things the nephrologist could have done medically as well. But yes, the family wanted him to come in and ask, how are you? How is he? What else can we do for you? So that's a very interesting story, isn't it? The role of a nephrologist all the way through and including the dying, rather than, I'm sorry, there's nothing more I can do. So what are the important things now to think about? Well, there's lots of different things in terms of the dying patient. The location of care, the privacy for the family, medical care, the nursing care is extremely important, spiritual care, and all of this is very much within the domain of palliative care, well, indeed everyone really. The family's view of the manner of dying and the care given will have a major effect on their bereavement and will echo down the years in the way they view death. So it can be that leading into death can be intimidating, confronting, and fearful. This is an interesting quote from a relative. When I look back on it, Dad had a good death. He was comfortable to the last. We were all there. In some ways, it brought us a lot closer as a family. Mum misses him, but she was glad he didn't linger on in the weak state he was in. In many ways, it was a lot more peaceful than I thought it ever would be. This is a remarkable statement from the son of this patient. The sense of the ambivalence of, yes, we're losing him, but we're glad that his suffering is finished, and also the coming together of the family. There are lots of fears that may come, how this will be, what to expect. And fears are very striking, can't they? And I'll let you look at that quote. So Pirandello was a great Italian writer, won the Nobel Prize for Literature, and 2 years later, he is now dying. And you can just imagine the doctor talking around it and around it. He said, no, I understand what's going on, doctor. This is called dying. So the barriers to diagnosing dying, that the patient may improve, no definitive diagnosis, unrealistic or futile interventions, disagreement, failure to recognise key symptoms, concerns about withdrawing or withholding treatment, inadequate preparation for it. So hopefully at the end of this lecture, people have a greater sense of that, poor ability to communicate, many, many barriers to actually diagnosing, I think this person is now dying. So I'm going to perhaps move from these slides. These are general slides about dying, and then move on to kidney story as well. What frightens you most? And people, their fears are the fear of the afterlife, leaving family and friends, unfinished business. The needs, relief of distressing symptoms, security of a caring environment. Prior to the terminal phase, there may be a lot of unfinished business. This is important for kidney patients. Unresolved conflicts, difficult family relationships, business worries, unfinished spiritual issues, and legal issues like drawing up a will. So we encourage people to try and do all this. Procrastination about these issues earlier in the illness, where no one is actually picking that this kidney patient is deteriorating and dying, may leave these issues unresolved, or worse, they are rushed in the pre-terminal or terminal phase. And this is a lovely quote in terms of what, I'll just let you read the quote. So what I see in families is the focus very much now on this one person, this one precious person to them, in this one bed, in this one room, and how all the other things of life start to disappear. So in response to, I'm sorry, there's nothing more we can do, how do we respond? So there's multiple answers to that question. For the patient, first of all, a comfortable bed, a pressure mattress would be ideal for the skin. Ceasing unnecessary medications. One approach in kidney failure patients is to continue certain medications as long as possible for the comfort of the patient, such as anti-anginals and diuretics. But we just carefully work that out. There's no absolute answer here. Ceasing unnecessary observations. We don't need to be doing observations on a dying patient. Ceasing unnecessary investigations, being careful to do that. If the patient is not swallowing, ceasing orals and using medications, consider converting all necessary medications into a syringe driver or an infusion. Mouth care, a moist mouth water spray, cotton wool sticks dipped in water. Note we're not putting up intravenous fluids on a dying renal patient, because that's going to rapidly set in pulmonary edema and worsen things. So the main thing is to keep the mouth moist, and that's so that the person is not feeling thirsty, and we can get the family to be involved in that using those things. An indwelling catheter, this is interesting because often dying renal patients assume that that's not an issue, but in fact that they may still be passing urine and go into retention. So several times we've been caught with this, an agitated patient, and in fact they were in urinary retention, and indwelling catheter was there. Symptom management, let's now go through. So we need to anticipate the general symptoms of dying and the management of uremic symptoms. So the general symptoms of dying, first of all, pain. Using subcut opioids. In renal patients, we avoid morphine, though we did talk about that in the pain lecture, that if you only had morphine, using small doses and widely spaced apart, remember like that? So there, look carefully for signs of discomfort or moving on turning. So if the patient is lying still and you go in, a classic doctor's mistake is to say this person's not in pain, whereas you turn to the nurses, and when the nurses are turning the patient, yes, they're groaning or grimacing, and they may well be in pain. Agitation or restlessness, so-called terminal agitation, subcut midazolam intermittently or in a syringe driver. Terminal secretions, that's the secretions that build up at the back of the throat, can be very distressing to the relatives. So what we tend to do is reposition the patient, that might be enough, or use medicines such as buscopan. Buscopan's famous as an antispasmodic, but it's also an anti-secretory, and glycopyrrolate can be useful there as well. So, general symptoms of dying, pain, not always, but we just need to look for that. Terminal agitation, terminal secretions, but it may be other symptoms. Now we've got with the renal patients, there's another set of symptoms overlaying all that, or overlaying or coming next to it, and that is uremic symptoms. So we've talked about uremic encephalopathy. What is that? So it's essentially a cerebral dysfunction caused by a buildup of uremic toxins. So it manifests as drowsiness all the way through to a coma, confusion, uremic jerks, these jerks that patients may have, and occasionally seizures. Fortunately, not that often, but that may be the situation. Okay, how do we manage uremic encephalopathy? So if it's a confusion or delirium, this actually may worsen terminal agitation. So using medicines such as haloperidol or midazolam. Also, you could actually be using clonazepam sublingually as drops in a dying patient, this also might be useful to help them. Uremic jerks, well, clonazepam drops sublingually or midazolam. That's what we use for those patients who start to have jerks, because that can be very profound and very difficult. So those clonazepam drops or midazolam. Seizure, well, absolutely using midazolam in sufficient doses to stop the seizures, and potentially having a syringe driver of midazolam as a continuous infusion. If the person's nauseated in the dying phase, remember we talked about using the metoclopramide, haloperidol, cyclizine. So particularly, as I've said, avoiding haloperidol and maxilline if the person's got restless leg syndrome, because you don't want to make the restless legs worse in the dying phase. So we might use other medicines, cyclizine as in addition. Pruritus. Well, we did cover pruritus in lecture number 2, as you'll remember. So what are we going to do in the dying phase? Because the person may not be able to swallow tablets, and we may not be using topical applications. So it's a challenge. Look, one school of thought is simply use midazolam if they're itching a lot. The difficulty with midazolam, it sedates the patient, but it may not take away the symptom of pruritus. So we've been using if they're swallowing oral medications, but if they're no longer swallowing, using lignocaine infusion, commencing at 200 milligrams in a syringe driver and elevating that dose by 1 to 200 milligrams per day, mostly to good effect. There's very little evidence about this, but it makes sense because lignocaine works on the itch fibers, on the sodium channels there. So I think that there's probably some rationale behind it, but not much evidence there. But we've been using it, well, not only in the dying uremic patient, but the dying cholestatic pruritic patient or paraneoplastic pruritic patient. So in other pruritic patients as well. Okay, so we've done a lot about the patient now. Now we need to turn to the family. So we need to ensure that there's an open, comforting environment for the family. I think certain things are very important: a single room so that there's some privacy, a stretcher bed so families can stay there overnight if they wish. If this is in an institution I'm talking about now, 24-hour access to children so children can come in as well. Familiar photos, art and music, and in a hospice setting, we ask the family to bring in those things. So that's very familiar. And also a garden or a place where people can sit out is nice. But I think part of the big story for families is emotional support and meticulous communication. So how do we do that? First of all, we need to speak plainly, in plain language. We should not be speaking technically. So I'm not saying to a family, he may get terminally agitated. They have no idea what that means. They get very scared by hearing that expression. I say he may get restless, and I'll show you. He may start to move around. He may get wet with his breathing. He may get in pain. He may get itchy. So I'm describing this. But as I said, each time, and if he gets that, we will do this, we will do that. So that can be very, very comforting for the family. Speaking slowly, not rushing here, because families are intensely listening to what you're saying here, and they're waiting to see what's going to happen. They've never seen this particular loved one die. They may have seen other deaths before, and they sometimes think this is going to be an absolute reproduction of that previous death, and reassuring them that no, every death is unique, and we're going to do our very best for this patient. So good communication. Then turning to the family themselves, are you eating? Are you sleeping? You know, it's very important to have a break. You are each other's greatest allies. Look after each other. Now, this is an interesting story in both the conservative managed and the withdrawal story from dialysis, or the dying patient of any renal patient, because this may take some days or even weeks. So we need to make sure that the family are having some rest and eating and looking after each other. That's very important, isn't it? Emotional, spiritual counselling, and then the priest, minister, imam, rabbi, monk, whoever is possible to come in for that patient is very important. The importance of good communication throughout cannot be overestimated. Statements made, asides given, even the demeanour of the health professionals and volunteers will be remembered and talked about for years to come. That's true. It's remarkable. Families remember all of this so intently, and this has been studied. how much families remember about these days, the look on the doctor or nurse's face, what they were wearing, who said what, did the nephrologist come in or not, what was going on here. So all of that will be remembered. And then finally, for ourselves as health professionals, we need to acknowledge the cumulative effect of our work on ourselves, and we need to take care of ourselves and each other. For nephrologists, I think this is very important because they're seeing, well, like all doctors and nurses, they're seeing a lot of death over time. And there's always an emotional sense from that. It may be slight, or it may be a form of grief that you've got to know that person very well. And I think recognizing that in nephrology and understanding that is very important, and certainly for juniors, so that we're not rocks or robots, we feel. So allowing nephrologists to talk through things, even potentially get together and talk through things about the emotional dimension of what they're going through is very important. And also nurses, of course, for everyone to have a sense of that. So I'll let you have a look at that, that quote. And for time to be alone with the loved one, of course. So that ends the talk. I wanted to perhaps just briefly touch on, with Professor Noble's presence here, and I'm conscious that there'll be questions as well. So I'll just perhaps maybe take one topic of those 4 situations that Professor Noble spoke about. That first topic is really difficult, isn't it? Metastatic malignancy, potentially a tumour wrapping around the ureters, causing obstructive nephropathy, renal failure, dying patient. What are we going to do? And I guess that's a really difficult question, isn't it? And often it depends on, well, part of course, depends on how well this patient is going, generally, globally, because it may well, this is now beyond any intervention. The person's prognosis is so poor, and the person's general state of anorexia, cachexia, etc., is so poor that we just need to be a bit careful here, that any intervention we do might start to make things happen quicker, or that there may be complications. And this precious time for the patient is now spent with being in theatre, recovering from a nephrostomy, all these different things. And it may actually may not give any particular benefit, or any benefit is very, very brief. But that's challenging, and especially as Professor Noble is saying, where the family is desperate for you to do something as a nephrologist. So Professor Noble, maybe I'm just conscious of time, but maybe briefly to speak about how you do respond to those families or that situation.
Yeah, we actually, if it is obstructive nephropathy, we try to put a PC nephrostomy tube, and some urine start flowing, some sort of renal improvement. And if relatives insist, we even do a dialysis and just make them symptom free, and convince them there is no point in continuing. So just a fluid removal, and then we'll ask them to take home and just be with her, and whatever possible you can be with them. And then we just counsel them, wait for this thing to happen. That's all. But
yeah.
we do some sort of symptom relief, like if it's obstruction, put some percutaneous nephrostomy or a bladder catheter. And if it's very fluid overload, we just 1 or 2 dialysis and make them symptom free and take them home. That is
Yes.
what,
I'm wondering then, in that situation where things are deteriorating, that sort of serious, do you have access to palliative care? Could palliative care come and be a partner for you, or be part of that process? Do you think that would help?
No, actually, till now, we don't have that opportunity. Just when Sridevi and the team came to me, I thought anyway, we'll also engage the palliative team to decide on the further course of action. I think for last week, we sent a couple of patients to them. And another problem in our institute is that they don't have an access to the inpatient. They have a palliative OPD, and we have to send the patients and the relatives to the OPD. That is another limitation. but we would like to engage them more in the inpatient setting. And that is what we are planning to do.
Yes, certainly in terms of just the psychology of that is really tough, isn't it? Because everything's happening incredibly quickly. The family are already they're perhaps not panicking, but they're very, very anxious about what's unfolding. And there's a lot of emotion here, isn't there? And certainly having palliative care to talk through that as well. In combination, and of course the symptoms, sharing the management of symptoms. So that is a, yeah, I can see that that's a striking example of the of perhaps the benefit of having the two disciplines working well together. But I might just turn to the chair there and allow questions to come through.
Thank you so much, Dr. Brennan, for that wonderful presentation. Dr. Sri is a bit under the weather and may not be able to continue for the time being. So I would request everyone to please use the chat box. It has been enabled to post your questions. We still have around 10 minutes for the discussion. Yes, sir. So we have our first question here. What is the recommended dose for magnesium in cramps?
Okay. Now, that's a good question. I'd probably need to look this up because with the crampies, which are available in chemists here, we get them to use 1 to 2 BD. But I'd need to look up the very specific dosing of that in terms of the constituent of the crampies. So I could perhaps get that through to Dr. Sri to her to disseminate. Somebody else in the audience may know the precise dosing, but yes, it's now the aim is not to give supernormal doses of lift the magnesium dose into excessive levels, but just simply supplement the magnesium, and that can be very good.
Thank you, sir. We have one more question. This is about depression. You said that we could use a small dose of sertraline. And again, the question is about the dosage of sertraline, which can be used in depression.
Yes. I'd probably start at 50 milligrams and then see how you go. You may go up, but I think what you would do would be to check where the EGFR is, the kidney function, and where that's, just to be cautious about that. But starting at, say, 50 milligrams, say, Nocte would be a good first step.
All right, sir. So there are situations where CKD very often leads to pulmonary edema, and Dr. Atul Suresh is wondering if furosemide nebulization can be used for the same.
Okay, so this is the story of secretion. So this is fluid overload leading to secretions, or simply secretions on their own, you think?
So I think this is related to fluid overload.
Yeah. So with fluid overload, we did touch on that in a previous lecture, because this is quite the challenge, isn't it? That in a yes, nephrologists will use increasing doses of diuretics and justifiably to try and clear fluid as much as possible. It may be that this is going to get a diminishing response as the kidney failure worsens, as they're getting their EGFR is getting less and less. So yes, using diuretics is fine, but then you may also be needing to use other agents for the shortness of breath, such as small dose opioids, anxiolytics like benzodiazepines, and the handheld fan, or the fan we talked about. So here, if the depends if the secretions are oropharyngeal secretions and maybe the terminal secretions, yes, glycopyrrolate would be entirely appropriate. If it's, on the other hand, it's mainly lower chest, as in fluid overload, well, it may not necessarily work. So you just, look, I mean, you could try it, but it may not necessarily work.
Thank you, sir. So even there is one more question. Now you told that Buscopan can be used for secretions, for reducing secretions as well. But compared to nebulization with glycopyrrolate, would Buscopan be better, or should we go for glycopyrrolate?
This is a very good question. I don't know specifically the answer to that question. I know that in some countries, Buscopan is used as first-line medicine for terminal secretions. Others, and whereas in Australia we would we would perhaps not use it that commonly, really. We would tend to go to glycopyrrolate. I'm not sure what you would have. So I think it's being confident in your own medicines in your own place. So if you're confident using glycopyrrolate, then glycopyrrolate is fine. But on the other hand, buscopan might be potentially could be used. And so someone's written here, glycopyrrolate will be better. So it may be that glycopyrrolate, is that the normal or the customary medicine in India?
Yes, so we use glycopyrrolate quite often.
Yeah, that's right.
Whereas mouth gargles is used sometimes.
Yeah, look, I think that's entirely fine, and that would be in keeping with international standards. But as I said, just to be aware that some countries might use buscopan as first line.
Right. Dr. Devi is asking, this is a little bit non-technical question. There is a weight of expectations which we have to cater to as well for a person living with end-stage renal disease. And, many a times the doctor may find it difficult to really, direct the patient towards conservative kidney management. So how should we go about doing that to initiate the conversation?
It's a really good question, isn't it? Because you're quite right. There can be an expectation, even a high expectation, that my father's got kidney disease, or my mother, or I've got kidney disease, and I've heard of dialysis, and I've heard that is the treatment. So now part of it depends, of course, on access to dialysis. Because that's really a challenge. Because if you've got universal access to dialysis, then in terms of working this out, we do know now that patients who are 75 and above with significant comorbidities, particularly ischemic heart disease, or poor functional status, may not get a survivorship on dialysis. So that we can say to patients, and say that it's going to be more appropriate for you to be on a conservative pathway. However, if you're in a situation where you don't have universal access, it's going to come down to, even if the expectation is there, it's going to be a question of finances. Can you afford this? Or, yes, we can afford it now, but can we afford it in 3 months, 6 months' time? And this is extremely challenging, isn't it? Because it really depends on your location, access to dialysis, what's possible, the finances of that family. So I think, this is very much a question for the nephrologists in your own country, as well as many nephrologists around the world. One of the stories there is that what's starting to come within nephrology is a recognition that nephrologists can still have a role in conservative management. So it's not that because they cannot offer dialysis, they've got no role. No, their skills are such that they do have a role in terms of all the things we've spoken about: preserving residual renal function, calcium phosphate, blood pressure, the erythropoietin story, fluid balance, all of that. So that's where more nephrologists are starting, and the ISN, International Society of Nephrology, is looking at the role of nephrology in conservative kidney management.
Right. Thank you so much, sir, for that answer. A lot of interest to muscle cramps. Again, there are questions being asked about, can we use methylcobalamin, L-carnitine, gabapentin, vitamin E, vinegar or yellow ginger, sprays of magnesium chloride. I mean, so many options being asked about, but your comments on these.
Yes. Well, look, this is really interesting, isn't it? Because it's such a difficult symptom that you can imagine lots and lots of things are being used. So, look, I think that there's not very many studies in this area. So we actually don't know. And when we don't know, lots and lots of different things are suggested, aren't they? Which is classic, isn't it? And everyone says, oh, why don't we try this or try that? So I think it's probably reasonable to maybe almost talk about the inner circle of those medicines and the outer circle. The inner circle would be medicines that have been used around the world to good effect so far, such as magnesium. But also, I'm conscious that L-carnitine is used in India. And I was I was online recently where one of the nephrologists spoke about that to good effect. Okay, well, that's really interesting. So that might be a second medicine that you potentially could use. Then I guess then you've got those the other ones, the ginger, the vinegar and stuff, maybe sort of sit sort of into the next circle, vitamin E, where there may not be any evidence for them, but it's possible to think about their use, particularly if the first medicines are not working. So that's probably how you would approach it, because yes, I think within palliative care, there's a principle of non-abandonment. We don't say, look, we have nothing to think about. So you could potentially start to move on those. And I'd be most interested from your participants, their experience in managing cramps with things like vitamin E, etc.
Right, right. So, sir, can skeletal muscle relaxants be used for cramps? And any topical approach like a massage or something like that, non-pharmaceutical approaches, would you suggest?
Certainly, I think certainly the non-pharmacological, the story of massage, people do speak about that well. It can be, it may vary time to time, whether massage on one day is better than another. It does require, I mean, you can try and massage yourself, but otherwise, having somebody else to do that might be useful. Muscle relaxants, it makes sense, doesn't it, to try them and maybe think about those. But it may or may not work. I guess you have to think of the mechanism and whether magnesium's coming back to that mechanism more precisely, if you like. So I think it's worthwhile just realizing that you could use medicines there just trying to work out what you could use and then trying them out. The worst thing to do is to say, I'm sorry, there's nothing I can do, because that patients get very troubled by that. Whereas versus, okay, even though we don't have a lot of evidence, why don't we try these bit by bit and see if this works?
Right. So there were some questions about drug interactions happening in the palliative care settings as far as nephrology is concerned, and especially concerns like with drugs like with Syndopa, which can which plays with the dopamine levels. So is there anything we should be particularly be aware of as far as major drug interactions are concerned?
Yes, well, certainly in that lecture, I pointed out a significant one, and that is the use of antiemetics that are dopamine antagonists, such as metoclopramide and haloperidol, and the possibility of triggering or worsening restless legs. So that probably is a standout one that we do see. Another interesting one, well, it's perhaps more what do we do in this situation? As you remember from the restless legs lecture, we also do use dopamine agonists to help them. Now, what if the patient is no longer able to swallow? They can't take those. So I suppose two other things that sometimes we do is one of those medicines was rotigigene, and that can come as a patch. So that's perhaps one way through that. Or I guess trying midazolam, though I'm not sure how well midazolam would work, but it's something to try in that context in a terminal patient. Yeah. So yeah, and then of course you've got lots and lots of stories in terms of medications and being careful with dosing, and that's really a medicine by medicine story, isn't it?
Right. We have already overshot our time, sir. I think I'm sure that participants will have more questions to ask, but please feel free to use the WhatsApp groups so that we can collate the questions and send it to Dr. Brennan later on and get a response from him. But apart from that, sir, we are so glad that we were able to conduct this for these 4 weeks. I think every session had over 100 participants with a mix of doctors from different backgrounds as well as nurses who handle a lot of symptom management at the field level, at their home settings, as well as in hospital settings as well. Any parting thoughts from your end, sir, on how we can go about not just advocating for palliative care in nephrology, but practically integrating it into the specialty as well?
Look, first, thank you for that question. And first of all, just to thank you and all your colleagues, everyone involved there with the ECHO and Pallium India. I very much appreciate this invitation to give these talks. I'm sorry that Dr. Sri is not present, because I was just going to personally thank her and her colleagues, all of you, for the kindness and openness for this invitation to talk through this. I think, look, I think things are moving in terms of kidney supportive care. This is interesting. Dr. Noble may be aware that the Indian Society of Nephrology and the Indian Association of Palliative Care have been conducting a series of virtual masterclasses on multiple aspects of kidney supportive care. So that's education. In terms of your question about practice, I think the model is that story of a conversation of a palliative care doctor and a nephrologist sitting down and talking about things. That's the beginning of things, and working out what is possible on the ground, just like Professor Noble and Dr. Sri have started, where they sit down and say, okay, what is happening here? What are the needs? What are the possibilities here? This is not an evidence-free zone. There's lots, as you've seen in these lectures, but generally there's lots more evidence coming through. We could potentially form an alliance and work out how to do things. Now, this may be an inpatient story, or it may be setting up a clinic, a so-called kidney supportive care clinic. It may be working with primary physicians. It may be lots of different things. It may be nurse-led with physician input. So that's a whole story. And the ISN, interestingly, at the very moment, has formed a committee on conservative kidney management. And one of the topics is an international curricula on this topic, but also a topic called creating and nurturing kidney supportive care services, the very thing that you're speaking about. So I think that will come. Be aware that there's work done in Nephpal, as you know, there on kidney supportive care, be aware of that. And also the work of Dr. Nandini Valath in Bangalore. So those two centres would be good to make contact with. In fact, I'd encourage Dr. Sri, Dr. Professor Noble to sort of, reach out to some of these other clinicians in those locations. The renal department at Nephpal, and then the at Bangalore, because they're already starting to create, or they have created, an alliance there.
Right. Thank you so much, sir. Once again, Dr. Noble, if you any parting thoughts from your end as well.
No, I felt that there is an urgent need to bridge this gap of nephropalliative care, and I think we are on the right path. Thank you.
Right.
Thank you so much, sir. Thank you so much, sir, for taking time out from your busy schedule as well, and Dr. Brennan for keeping up, staying up, for conducting the session for all of us. We hope to continue the good work which all of us have been doing as a collaborative effort, and I'm sure that seeing the interest in the participants and the practical possibilities on the ground, we'll stay connected, and we'll get in touch with you very soon once again.
Anytime, of course, I'm very happy to help. So thank you so much for chairing, and thank you so much for everyone. It's been great to have this time with you. It's been really good.
Thank you, sir. Have a good evening, everyone.
And
Bye-bye.
Good evening, everyone, of course.
Closing up.